Give the introduction.
Do you want me to start with the slide share?
Yeah, we will tell you just in 2 minutes. Dr. Srinivas? Yeah, Dr. Srinivas, we are live.
You give the introduction. Just
okay.
Statement.
Good day, everyone. I hope everyone is fine and keeping safe. We are on our next session of Learning Basic Arthroscopy series of lectures. Today we have a good discussion coming up on tibial plateau fractures in general, and also the role of arthroscopy and more complex treatment options in tibial plateau fractures. I kindly request Dr. Srinivas to introduce the speakers, and then I will go ahead with the introduction of my friend and teacher, Dr. Diago.
Good evening, everybody. Welcome back. We have Dr. Chirag from Bangalore and Mr. Rajarshi Bhattacharya from London. I'll just introduce both of them. So Dr. Chirag Tonse is a consultant orthopedic surgeon at Vikram Hospital, Bangalore. He has special interest in shoulder and knee surgeries and trained extensively in India and abroad. And he's a faculty in various national conferences and cadaveric courses since 2013. And he's successfully running a fellowship program in arthroscopy. Welcome, Dr. Chirag. He'll be starting off with the talks. And Mr. Rajarshi Bhattacharya, he has appeared once before. We had a detailed introduction of him with Dr. Tapasvi's session. He's a clinical director of orthopedics and plastic surgery and major trauma at Imperial College Healthcare NHS Trust in London. And he's an honorary clinical senior lecturer at Imperial College and also president of orthopedic section at the Royal Society of Medicine in London and clinical advisor to Parliament and Health Ombudsman in UK. Welcome, Raj. Can I introduce, can I request Dr. Chirag to open up the talk, please?
Yeah.
Yeah, just give me 1 second. Let me please introduce our guest moderator. It's an honor to welcome Dr. Diago Costa Astur. He is Chief of Knee Group and at Sports Traumatology Center and affiliate professor from Federal University of Sao Paulo. It's very difficult to give a complete introduction about Dr. Diago. His CV goes on to around 14 pages. His main interests are arthroscopy of the knee, arthroscopy and sports medicine. He is also very experienced in traumatology. He has multiple papers, around 75 in international journals, including JBJS, arthroscopy, KSSTA, and AJSM. And he is also very experienced in pediatric ACL injuries. As I said earlier, he is affiliate professor in the Department of Orthopedic Surgery and Traumatology at Federal University of Sao Paulo. He has completed his doctorate in the same university. He is head of the Knee Group and Sports Traumatology Center. And he is also a member of the Overload Injury Group at the Sports Traumatology Center in the Department of Orthopedics and Traumatology at UFSPA. Welcome, Dr. Sao Paulo. It's a pleasure and honor to have you here. I now welcome Dr. Chirag to start sharing your screen and go ahead with the presentation. Dr. Chirag.
Yes.
Dr. Chirag, are you here? Are you there? Yeah, you can go ahead with the presentation.
Am I audible? Can I get some?
Yes, you're clear.
Yeah. So today we have a good evening, everybody. And first of all, thanks for the team for inviting me for this wonderful session this evening. I hope we bring in some good discussion going forward with this topic. It's a very, very important topic, and it's a very common kind of problem what we see in our day-to-day practice. Maybe a trauma surgeon, maybe an arthroscopic surgeon. Proximal tibial fracture is something which is bread and butter for every orthopedic surgeon, as what I could say. A proximal tibial fracture, as we all know, let's just look into the incidence of what kind of an injuries we encounter or we see on a routine basis. A tibial plateau fracture accounts for 1% of all fractures in the body, and out of that, about 60% are unicondylar fractures, and out of these unicondylar fractures, about 90% of them are lateral tibial plateau fractures. Now, the intercondylar eminence, that's the avulsion fractures, accounts to about 10% of these proximal tibial fractures, and the bicondylar fractures account to about 35%, 30 to 35% of these kind of tibial plateau injuries. So, by large, the larger chunk of these tibial plateau fractures are the unicondylar fractures, and these are the fractures what we are going to talk about more in today's discussion or today's topic. It's a well-known fact that what we all of us do follow to classify these tibial condyle fractures right from our post-graduation days is a very simple classification given by Schatzker, and it is either the type 1, which is the split fracture, the type 2, which is the split depression fracture, the type 3, which is the isolated depression fracture, type 4 is the medial tibial plateau, type 5 is the bicondylar fracture, and type 6, which is the more notorious ones, which is called as the metaphyseal-diaphyseal dissociation or the metaphyseal-diaphyseal injuries. Now, why these proximal tibial fractures are notorious? Because there's a lot of vascularity disruption in these kind of fractures. Now, the proximal tibial blood supply, if you look into, we either have it through an intermedullary blood network or else through a periosteal network. And what happens in a proximal tibial fracture? When we have a proximal tibial fracture, one, the intermedullary network gets disrupted. So there's a primary injury of the vascularity for the tibial condyle. And next, what happens? We end up doing a large extensive approach, extensile dissection, and what happens is the periosteal network of the blood supply is stripped off. What does this lead on to? This leads on to the risk of infection, necrosis, and of course, some of these fractures, especially the bicondylar or the type 6 kind of a fracture, is more notorious for non-unions. These are all the day-to-day problems which we encounter in the proximal tibial fractures, and this is what makes proximal tibial fracture treatment more challenging. Hence, looking at all these problems, people did make an attempt to minimize the exposure, to minimize the dissection, and to quicken up the surgical procedure, and was an advent of arthroscopic assisted percutaneous fixation of these tibial condyle fractures. This was first described in 1980 by Kasperi and Jerings. They did describe in their literature arthroscopic assisted percutaneous fixation. This was, mind me, it was as early as 1980. That's about 40 years back. People did talk about arthroscopic assisted percutaneous fixation, and for various reasons, it went down the lane. It was kind of not very successful during those days, probably because of the lack of the clear indications or lack of advanced instrumentations could be one of the reasons why this did not pick up that pace which it should have picked up for the kind of innovations they had. Now, the role of arthroscopy is very, very limited in type 5 and type 6 fractures, and this is very controversial. Now, by large, which I'm going to talk about is a percutaneous fixation or else an arthroscopic elevation, is restricted to type 1, type 2, or type 3 fractures. Now, type 4 and type 5 and type 6 fractures, role of arthroscopy or minimal invasive procedures are very, very bleak, or we should be very, very selective in such cases. And even if you are doing an arthroscopy, we need to be very, very watchful about the compartment syndrome which can happen there. We should be watchful about our reduction, and of course, rigid fixation is very important. Hence, even if you are doing an arthroscopy for a type 5 or type 6 fractures, just put in an arthroscope, assist your elevation or the fracture reduction, then go ahead, do a good dissection and fix these fractures with a good rigid external plates. Now, this is something which we need to look into. Most of our postgraduates would come ahead and say, sir, along with a lateral tibial condyle fracture, there is an valgus test which is positive. Probably he has an MCL tear. Now, this is what we have to be careful about, a pseudolaxity. So what happens in a lateral condyle depression fracture? One would get a pseudolaxity of the lateral or else a medial opening, which would mimic a MCL injury. One needs to be very aware that it could be just because of your depression fracture. Hence, don't get tricked by this and don't infer that you have a medial collateral ligament injury. Hence, a thorough evaluation in terms of X-rays, CT scan, and if required, MRI is very, very important for these kind of proximal tibial fractures. Now, a basic routine is to get a X-ray, AP view, a lateral view, which would give us an initial idea as in what we are dealing with. Is it a type 1 fracture, type 2, or type 3, or type 4? That would, anyways, our X-ray would say. Why go in for an advanced CT scan? One would definitely want to have a 2D CT scan or a 3D CT scan in these kind of proximal tibial fractures to understand the fracture pattern, to exactly locate where the injury is, what kind of a fracture is it? Is it a sagittal plane? Is it a coronal plane, or is it a biplanar fractures? To evaluate or quantify the bone loss in case of a depression fracture or a split depression kind of a fracture. That's not the end of the story. In our practice, since we are most of us are arthroscopic surgeons, we would further on go one step ahead and get an MRI scan done. It's very helpful to single out any ligament injuries or if any suspected meniscus injuries are there. Now, by literature, there's chances of about 2% to 47%. Like on a routine, we would see about 20 to 30% of these proximal tibial fractures do come with a certain amount of meniscus injuries. Maybe most commonly, if it's a lateral tibial plateau fracture, there could be a meniscus disruption, a capsulomeniscal disruption, or else an entrapment of the lateral meniscus, which would be missed out if we wouldn't have got an MRI scan. Also, about 4% to 32% of these kind of injuries are associated with ACL injury. So it's a complex injury. When we are talking about dealing with the proximal tibial fracture, we are not dealing with a bone per se or bone alone. We are dealing with the bone, we are dealing with the soft tissue, and we are dealing with the ligaments. So we need to, the treatment lines needs to be complex, and each and every single structure around the knee and the soft tissues need to be catered in a proximal tibial fracture for an absolute good outcome. How do we go ahead with this kind of? Now I'm going to talk about an arthroscopic assisted proximal tibial fracture fixation. This is very interesting surgical procedure. It is quick, it is precise, and it minimizes the exposure of a radiograph. Now, what are the basic instruments which is required? Basic instrumentation includes a tibial jig, and that's the ACL tibial jig. I usually use a tip aimer jig, a guide pin, that's the bead pin, and a 10 millimeters tibial reamer, ACL reamer, along with the basic arthroscopic instruments. Whenever you're dealing with these kind of proximal tibial fractures, you plan in for an arthroscopy in your armamentarium, please keep all your meniscal repair and your ACL reconstruction kit available. You do not want any surprises. We do not want to get tricked by these surprises. If we find a meniscus repair and a meniscus injury, we should be in a position to sort it out there and then, as well as fix the fractures, rather than go ahead and do a second surgery. In our practice, we usually keep all of these things ready before the surgical procedure. How a surgical procedure would start is with the proper positioning. I usually do this procedure in a supine position with the normal irrigation, that's the normal saline, 90 degrees knee flexion with a bolster and a side support. Routine arthroscopic portals. The viewing portal may be AM portal or AL portal. You can switch the portal depending on where your fracture site is, where the depression fracture is, either most commonly the lateral. So the lateral side becomes the viewing portal and medial side becomes the working portal. You can always have an accessory portal. In case you do not get a trajectory with your ACL jig, you can always use an accessory portal. Remember, no matter how many other portals you put, it just makes your life easier. Don't struggle with portal placement. Don't be stubborn that I'm only going to put one portal or two portal. Remember, until unless you connect these portals, it's always an arthroscopy procedure. Only when you connect these portals, they become an open procedure. So you can put one portal, two portal, three portals, or multiple portals to get a good visualization, to get good access to where your fracture site is, and to get a good access to for your instruments. The surgical procedure would start with a basic marking of your patella. This is just a basic marking of your patella, your tibial tuberosity, mark out for your joint lines, the medial joint line, the lateral joint line, mark your patellar tendon. As in case a few of our beginners are watching this surgical video, it's very important you do not miss out on this initial trick to mark out your bony landmark, because there can be a lot of effusion and it's very easy to miss out your portal placements. One could have a routine portal placement, that's a standard anterolateral portal or a standard anteromedial portal. What I do is I put my viewing portal, that's the anterolateral portal, a little more medially and superiorly, so that you escape the fat pad. In these kind of injuries, in this kind of a complex injuries of the knee, usually you tend to have a fat pad disruption. So what happens? You put your portal in the center of your lateral side. You tend to disrupt the fat pad more, and your vision becomes blurred. So fat pad is like a triangle. So I tend to put the portal much more superiorly at the apex of the triangle, so that as much as fat pad you can escape, it's better for you, so that your vision is much more clearer. Once we're done with that, the next step is to evacuate the hematoma. It's a fresh injury, so the vision is blurred. Spend about 5 minutes, 10 minutes, 15 minutes just to clear out all the debris, clear out all the hematoma, get a good vision. The shaver blade helps in aiding removing all the hematoma. It also evacuates all these smaller debris what we find in these kind of fractures. Supposing it's a complex fracture, you can have a lot of fat globules, you can have a lot of these smaller bony fragments. Take the shaver and give a good wash with about 1 liter or 2 liters or 3 liters of saline and get a clear vision. Let me just give you a pictorial depiction of what our procedure is going to be before we are going to watch into the surgical video. The first part towards doing this procedure is to evaluate the lesion. It's very important that we understand the lesion. We need to understand, is it a split kind of a fracture? Is it kind of a depression fracture? Is it in the anterior portion, posterior portion? So that we know how to place our jig. Once we evaluate the lesion, if we find any form of a meniscus tear, go ahead and repair this meniscus tear. Once you repair the meniscus tear, use the ACL jig, a tip MR jig, point it or place it at the center of the defect, and then introduce the bead pin. Once the bead pin is introduced or a guide pin is introduced, open up the cortex of the tibial condyle, open up the cortical window, and then use the instrument to elevate the fracture. And then if the fracture defect is too much, I mean, for us, more than 6 millimeters of depression is considerably a larger depression. So you can assess this kind of a depression, the millimeters of depression, or quantify the depression defect with your preoperative CT scan. And then if the defect is more than 6 millimeters, go ahead and use the strut graft, or use the cortical graft, or a cortical cancellous graft, or else use the bone cement, which would give much more steady support for these kind of an elevated fractures. Let's quickly look into the surgical video. We are by large, this surgical video is acceptable for a type 1, type 2 or type 3 fracture. Ideally for a type 3 fracture, which is a isolated depression fracture of the femoral condyle. As we see here, there's a young gentleman of 30 years old who came with a road traffic accident, type 3 fracture. The first thing what we do is visualize, or as I said, identify the fracture fragment. As you see here, the patient is placed, the leg of the patient is placed in a figure of 4 position. Now what happens in a figure of 4 position? The lateral compartment opens up and you have a good access. You can visualize the defect, you can see the defect, and identify the defect. The next thing what we need to do is use a tip aiming jig, or ACL tip aiming jig, tibial jig. So you can angle it at about 55 degrees to 60 degrees, and then place the jig, the tip of the jig, in the center of the defect. As we can see here, this is a huge defect of the lateral tibial condyle, and I'm placing the jig right in the center of the depression fracture. As we place it there, one would then go ahead and evaluate the defect, how big is the defect and how deep is the defect. Here we can see there's a good, nice depression fracture of the lateral tibial plateau or the lateral tibial condyle. Once you place it in the desired position, keeping the limb in a figure of 4 position, one would then go ahead and introduce a bead pin or a guide pin. Just stop it just subchondrally. You can take the assistance of a CM or image intensifier. Do not pierce the articular cartilage. Just stop about 3 to 4 millimeters or about 1 to 2 centimeters below the articular cartilage. One would then take a 10 millimeters tibial reamer and then open up the cortex. This is like in the old times. Previously what we used to do, we used to take drill holes or use an osteotome and open it up. Now we can just use that same reamer once we have created a cortical window, use the same reamer to elevate the fracture site. Now, if we find that the fracture elevation is not even or it's not in one plane, one could always change the angle of the guide pin or of the reamer and then elevate the rest of the lesion. And hence you can see once I have elevated the entire tibial plateau, I usually over elevate the lesion for about 1 millimeters or 1.5 millimeters so that we can start with the knee range of movement and start with the early knee range of movement, and we can start with the early weight bearing. Over elevation is always better than under elevation of these kind of defects. As we can see here, sometimes what we see that there could be a meniscus tear, a meniscocapsular junction disruption, any popliteal tendon disruption has to be seen, looked in for. Posterolateral corner injuries have to be ruled out. Any kind of meniscal tear which we visualize here can be repaired. Look into the root of the meniscus, look into the anterior root and the posterior root. Sometimes there can be an entrapment of the meniscus. Make sure that your meniscus is completely free, and in case there is any residual peripheral elevation of the defect which is left, one could take a curved ring curette as I've taken there and elevate the lesion. One would then go ahead and fix this elevation or provide a support for the elevated bone with 1 or 2 4 millimeters or 6 millimeters cannulated cancellous screw. This is how one would see the congruence of the reduction. As I said, if the depression is more than 6 millimeters, I would then go ahead and push in a little bit of a bone cement, or else I would take a corticocancellous bone graft and then punch it to give it much more support for this kind of elevated fracture. Now, what's important? The most important thing in these kind of patient selection is to have a good cortical envelope. Now, as we can see here, this kind of a fracture is a type 3 fracture with a good cortical envelope. It's very important that this integrity of the cortical envelope is intact. What happens if it's not intact? Example, this kind of a fracture, there's no cortical envelope which is intact, it's already disrupted. In case we plan to elevate or do arthroscopic elevation in these kind of fractures, the bone is going to get disrupted. We may not get the desired elevation, we may not get the desired reduction, and then we may get we may not achieve the desired results what is required. What are the advantages of this procedure? A precise trajectory. What happens most of the times, we do not use the ACL jig. If we do not use the ACL jig, we do not know what trajectory to go in for. So we make a cortical window, and it's a trial and error. You need to probably under CM guidance or blindly place your elevating instrument in different planes and see. It's a trial and error method, and hence we end up creating a larger defect in the subchondral bone, and then we'll have to unnecessarily fill it with bone graft, bone cements, etc., etc. And hence, if you're using a tibial jig, the trajectory is precise. You can minimize the risk of compartment syndrome because your operating time reduces. You have a precise trajectory that reduces your time much more, and you do not need to extensively use your CM and have unwanted exposure to X-rays. Furthermore, should I continue with the proximal tibial open fractures as well?
Yeah, you can give a gist of it. You can continue, please.
Yeah. I will just brief about the three-column concept. We all know, I mean, just to brief about a few things which we miss out on an open procedure as well. It's very important that we understand the three-column concept, that whenever you have proximal tibial fracture, we're talking about the type 3 fracture, type 4 or type 5 fractures. This could be in multiple plane. We usually divide the proximal tibia into medial column, lateral column, and a posterior column. So it could be a combination of any fracture. It could be an isolated posteromedial condyle fracture. It could be an isolated posterolateral condyle fracture. It could be posteromedial with posterolateral condyle fracture. The fracture could be in a coronal plane or a sagittal plane. So we need to understand, we need to probably try and figure out the three-dimensional picture of what exactly we are dealing with, so that our fracture reduction and fixation becomes easier. Look at this example, mixed fracture fixation. This is very, very common. This is a common scenario where the patient comes to us about, this is a patient who came to us about 7 months post his proximal tibial fracture fixation, and the operating surgeon has comfortably missed out the posteromedial condyle. Hence, the patient came with pain and deformity, and then we had to go ahead and revise this fracture with the posteromedial plate. So a posteromedial condyle or a posterolateral condyle fracture which is missed is very, very common to see in practice. Let me just brief you about how we need to identify and fix a posteromedial condyle fractures. And most commonly, we do this in a prone or a supine position. It can be done either in a prone position or a supine position. I usually do it in a supine position with the leg in figure of 4 position, which gives us a good access to the posteromedial condyle. Case 1, it's a complex fracture with the medial element and a posteromedial condyle element. On NCT, we see that it's a bicondylar fracture, and it's more of a posteromedial condyle which is fractured. Preparation as routine, and the incision would be just in the posterior aspect of the tibia, in line, curving it more towards the inner aspect. Once we identify the pes anserinus, it's very important to identify the pes anserinus, tag the pes anserinus. Either you could split the pes anserinus, cut the pes anserinus, or else just go below the pes anserinus. But it's very important that we identify and preserve the pes anserinus after a surgical procedure. Once we identify the fracture, take an osteotome and open up the fracture and elevate the fracture with an osteotome. And once it's elevated, I usually take a patellar reduction clamp and reduce the fracture, and put anteroposterior lag screw to stabilize this fracture. Once it's stabilized, one could take either a T-buttress plate or a posterior condyle plate, or else one could take a simple recon plate and then fix this fracture. And once it's fixed, it's very important that we close off the semitendinosus. Yeah, this would what one would achieve. Lag screw with a posteromedial condyle plate. Since the lateral condyle was undisplaced, one wouldn't really bother, or else one could just put one screw percutaneously from lateral to medial side to stabilize this lateral condyle. This is the immediate post-op after 3 months, and that's how a scar of a posteromedial condyle fracture would look like. I'm not going to, since I'm an arthroscopic surgeon with minimal experience of trauma, I'm not going to elaborate on much on the open fractures and the treatment lines. Probably my subsequent speakers would do that. I would once again thank the team for giving me this wonderful opportunity, and let's carry forward with the discussions. Thank you.
Thank you very much, Dr. Chirag. That was a beautiful presentation. You gave us a lot of clear details about how to manage a tibial plateau fracture and also the arthroscopy part of it. Thank you very much. I now welcome Dr. Rajarshi Bhattacharya to proceed with your presentation, please.
Sure. Can you see my presentation?
So clear.
Okay, right. Thank you, Dr. Saseendar and Sri, for getting me in once again. Thank you to Dr. Thonse for a very nice talk on arthroscopic tibial plateau fixations. I'm going to move slightly away from arthroscopy and talk a bit more of some of the key general points of tibial plateau that I think are important, and also on some of the sort of more complex cases, and finish off with the use of current technology as we see it going forward in tibial plateau fractures. So I work at Imperial College, and we have 3 main hospitals there. So on the left, you see St. Mary's Hospital, which is where we have the Northwest London Major Trauma Center. You can see a little plaque there, and although you can't read it, I can tell you basically this says that on the first floor of this building, Alexander Fleming had discovered penicillin. So this is quite a sort of an important landmark in the medical world here. The middle building is our Charing Cross Hospital, where we do all the trauma work, elective work. And on the right, we have the Hammersmith Hospital. So these are the 3 hospitals that I work in. My complex tibial plateau fractures all come to St. Mary's Hospital. And Dr. Thonse has already covered the majority of the basic principles and concept of it. So I'm just going to go through a few slides where I'll highlight the things I feel are important and that allow me to treat these fractures properly. Now, to start off with, I'm just going to try and go through a few cases. So let's start off with this one. So this is a 56-year-old gentleman who had a motorbike crash. He was intoxicated. He's a banker, so he's quite rich and well off. Doesn't stop them from being stupid. Now, what I want to concentrate here is the picture on the right. And we all get, as orthopedic surgeons, we get excited about broken bones. But to me, this broken bone is a very small piece in the whole jigsaw. And the key here is the picture on the right. And if you haven't got this correct, then this is just going to be the first step of a very bad outcome with possibly even amputation. So for me, these are usually bony breaks, but mainly soft tissue injuries. And we'll go through how I deal with these later on. But essentially, we did what we normally do. So we usually span these fractures, then we scan them, and then we plan them. And if you look at the fracture pattern here, I put up the axial views because I personally feel the axial views give me a huge amount of information. You can see where you need to support this fracture, and you can see where you can enter this fracture. And those are the 2 key points for me when I'm planning any surgery for these kind of complex injuries. The coronal and the sagittal views are also important. They give you an idea of the degree of depression and also of the fragment, the posteromedial fragment, so to speak, or the posterolateral fragment if you have one. And essentially for me, these fractures are dealt with using 2 separate incisions with a plate at the back and one on the front on the anterolateral aspect. He had this fracture fixed, he was doing well, and then he went back to his bike after 6 months and did this. And he came back to us again, not in great shape. Thankfully, this time the soft tissues were not bad. So we took him to theater, took out the plates. You can see half of the screws were broken, but we went back and did exactly the same thing and eventually managed to get him back on track. So this is kind of where things can go wrong. And that's why I want to focus and concentrate on these fractures a bit as we go through the talk. For me, the key here is these tibial plateau fractures are bimodal. So you can get them in young adults and you can get them in older females, and they are completely different beasts and should be dealt with in a very different way. The main problem, as I see it, for these tibial plateau fractures is it is a large weight-bearing joint, and you've got the variable etiology. You can have a very osteoporotic bone where you have bone failure and the bone crumbles, and there's a different way of dealing with those. And then you've got these really high energy injuries. And pretty much most of the high energy injuries have got associated other pathology, as Dr. Thonse mentioned. The advantage that we have here is literature shows us that we kind of know what makes things go wrong and what gives bad results. So residual instability and malalignment gives us bad results. We also know that open erosion and internal fixation gives us reasonably good results. And long-term functional outcomes are satisfactory. Even 10 years after tibial plateau fracture, only a small proportion of people actually have to undergo knee arthroplasty. So generally, the nature is helping us out in the treatment of these, and it is mainly for us to go and screw it up. So for me, the main aim of dealing with this fracture is to restore the anatomy, articular surface, but actually for me, the key is more about restoring the alignment and restoring the stability. The articular surface anatomy, you can get as pedantic about it as you can, but I think unless you have these two sorted, you're not going to get a good result. Failure can take various forms. You can have all of these things: displacement, malalignment, instability. Of course, pain and stiffness are very relative terms, but for the patient, if they have those, they consider it a failure. It doesn't matter how good the fixation is. For me, the assessment of the fracture is kind of key. And I've just highlighted here the two things for me that stand out is soft tissue and neurovascular status. And please make sure that you document the neurovascular status when you're assessing the patient, because this is the last chance you will have before patient goes to theater. And if anything has gone wrong later on, you will not have anything to cover yourself. The soft tissue, as I mentioned, and I'll keep mentioning, and I make no apologies for it, have to be looked at, they have to be respected, and they have to be dealt with properly. I have to say that I don't really find 3D CT reconstructions very useful. They're quite fancy and they look nice, but for me, the 2Ds give a lot more information. It allows me, as I said, to show my path of access and also where I need to put my plates to get support. MRI scans, I do tend to do them because I want to know what the ligaments are like, and eventually they may need repairing or reconstructing at a later date, but usually not at the time of the fracture fixation, unless I'm doing something like an ACL repair as well. We've talked about Mr. Shaska and his classification, so I won't go into that. Again, just 2-3 key points in each of these. The Shaska one is a valgus stress. It usually happens in younger patients who have stronger bones which resist depression, and that's why they crack. And Dr. Townsend mentioned, and I agree, that there can be a pseudo laxity, but because of the mechanism, you tend to sometimes have an MCL stress. And usually, once you've repaired and elevated the lateral compartment, it just heals by itself, but just be aware of it. In Shaska 2, the bones do not resist depression. That's why they crumble more so than the first one. And in Shaska 3, it's usually an osteoporotic fracture in older patients. If the depressed fragments are towards the back and lateral, they can be associated with joint stability. So beware of that. And to be honest, I have to say, I find Shaska 3 patients quite rare. If you look carefully, the majority of them have that small split that goes to the front that converts a 3 to a 2. So I don't get to see a lot of 3s. When you come to the 4, 5s, and 6s, which is what I was talking about, they're a complete different beast. And there's a lot more associated with them, particularly the arteries and the nerves. I want to talk a bit on the 4s and 5s, because although they are part of tibial plateau fractures, to me, this is actually a same mechanism as a knee dislocation. So if you look at, this is a subclassification of the 4s, where as you go lateral with your fracture line, it gets more and more severe. But if you think of the 4s, if you think of this fracture, this medial condyle is attached to the knee, and the whole of this has actually moved out and come back. So this behaves in the same way as a knee dislocation, and that's why they have to be treated in the same way as well. 5s, again, interestingly for me, I find them very rare. It's always ends up either being a 6 or stays a 4. But yeah, very occasionally you do get the 5s. And then of course the 6, Dr. Townsend has already mentioned, and they have these associated injuries. So coming to initial management, yet again, soft tissue envelope and neurovascular exam. This is the key for me. Everything else, everybody knows, and we just do them as a routine, but these are the bits that get forgotten. The principles for me for definitive management of these fractures include reduction of the fracture to restore the anatomy, stabilize the fracture, preserve the blood supply. You saw Dr. Thornton showed you how the blood supply comes to the proximal tibia. And then obviously try and mobilize safely. I do have certain cases where I will treat them non-operatively, and for me, this is the algorithm. It's mostly for lateral plateau fractures. Very rarely would I actually end up treating a medial fracture non-operatively. I tend to accept any articular step off which is less than 3 millimeter, and as long as there's no condyle or widening. I do not think varus malalignment does very well, so I don't accept any varus malalignment. Valgus tilt I can accept a bit. And then they get a cast or brace, then partial weight bearing. And the key is be prepared to intervene if at any stage you feel that the fracture is not doing what it should be doing. So the principles for me is a combination of the personality, and it's not just the fracture personality, it's also the personality of the patient, your surgical ability, and the implant choices that you have. Not everybody can do every operation well, some that do certain things perfectly. So be aware of that and send it to the right people if you can't do them. And also be aware of the implants that you have and that you need. So if I just quickly go through my setup and approaches. So this is the kind of setup I have. You've got the patient and sit at the top. I normally sit on the side of the injured leg with my assistant and the scrub team, and the image intensifier comes from the other side. So you can have, as Dr. Sansa mentioned, various ways of dealing with this. I personally like sitting on the side, well, just on the front of the leg, and having the leg dangle down, and this is my typical setup. And the key for me is the ability to have that drill go from back to front. Therefore, I tend to bring the leg of the patient slightly out from the table. That gives me this access. And what you really want at the end of the operation to have these skin incisions, which are separated by a nice skin bridge that is not going to be threatened at any stage. The principles of treating this, we all know. Shasga 1 is usually using ligament rotaxis. You can use a lag screw or anti-glide plates, and you can have 1 or 2 screws. Shasga 2 is a usual typical one where you tap from the bottom and you put plate to fix it. You can use a lateral parapatellar approach. You can use a hockey stick incision. You can go above the meniscus. You can lift the meniscus. It doesn't really matter. But again, for me, this is the key. This axial view gives you an idea of where you're going to enter and where you make your skin incision. I will sometimes use an arthroscopy, but I tend not to be in favor of using an arthroscopy if I've seen that there's a Shasga 2, because I always worry about compartment syndrome. So certainly I would not use any pressure on the fluid. It'll be gravity assisted, and I'll do only the minimum amount I need to without spending too much time. And this is generally how I do my operations. Sometimes we will just elevate it and put cement and put some screws on. John Keating had shown that these work equally well, but most of the time you've got plates and screws on. The Shasga 3s are the ones that are quite fun to fix arthroscopically, and there's probably less danger of compartment syndrome. But as I said, I don't see Shasga 3s very, very commonly. There's always that cortical breach, which makes me worried about extravasation of the fluid. But you can use the arthroscopy techniques in these and put some screws to fix it once you've elevated the fracture. You can use percutaneous techniques using the image intensifier as here as well. And generally, there are studies that have shown that 4 small screws are better than 2 large ones in terms of movement of the fracture afterwards. I won't talk too much about the 3-column principle because Dr. Thorns has already mentioned, but the key for me here is the ability to get to the back of the knee, both on the medial and the lateral side. And you've got to be able to do that if you're going to deal with these complex injuries. And as I mentioned to you, this Shasga 4, now think of this particular fracture. This whole medial femoral condyle is attached to the femur, and the lateral condyle, or just whatever is left of that, and the rest of the tibia actually moves away. So this, to me, is actually a knee dislocation, which has then reduced itself. And the chances of this being associated with nerve and artery damage are very, very high. So these have to be, in my book, treated with, well, investigated at least with the CT angiogram. I have all my Shaska 4s, 5s, and 6s. They get CT angiogram, not just because of investigation for the actual injury at the time, but also I would like to know if I'm getting any intimal damage, because if I do operations on these patients, they take quite a long time, and you don't want a long period of tourniquet time if you've got intimal damage to these. The key for me is this: you've got to be able to get right to the back of the knee to be able to buttress this fragment and put your plates there. There is absolutely no point. I'm still amazed at the number of times I see the single midline incision trying to get into the front, the medial and the lateral side, and you get the plate. I'll show you later on. You get the plates put on the kind of side of the tibia, hoping it will work, and it doesn't work because you haven't really addressed the problem here. So you've got to be able to get to the back of the knee, and if you can't, then get somebody else to do it who can. And I use this approach. This is called the tricky approach. It's not because it is tricky to do, but it was after a gentleman called Tricky. And essentially, this is looking at the posterior medial condyle, beneath the popliteal fossa and the gastrocnemius. I tend not to dissect the hamstring, the pes. I go either above or below them and try and slip the plate. If I could, if I'm really struggling, then yes, sometimes I do take them out. And that's how I do it. Now, going back to the 5s and 6s, all of those things that we talked of come much later. The initial bit is to try and get this appearance to look much better when you're planning to take the patient to theater, because if you don't, then you're in for trouble. And once you've got your leg in a state to operate, it doesn't really matter what you do as long as you do it correctly. You can do open reduction, you can do minimal invasive, you can do an external fixator, you can use a single plate, you can use double plate, you can use locking, uniaxial, polyaxial. There's a whole bunch of stuff that you can do, and you will all be good at doing your own thing. But the basic principle is you cannot rush in to operate on those until the soft tissues have settled down. And we do still see these things, and it saddens us that this is still happening. There is no place for these kind of bone sandwich, dead bone sandwich, as we call it, between the two plates. This is the classic posterior approach to the knee. As I said, we don't really need this a lot of times. This is the tricky approach that I mentioned, where you actually only use part of that posterior approach, and you can go on either side. And as you can see here, you can get good access to both the posterior medial and posterior lateral. Of course, the posterior lateral is slightly more difficult because of the nerve in there. And what you really want to be able to see is that plate going right at the back. So if you take a lateral view, that should be the profile of your plate. And if you see an AP view, that should be the profile of the plate, nothing less. If you see this, I mean, this fracture eventually did go on to unite, but not because of what was done, despite what was done. And this is what I'm saying, that the nature is actually trying to always help you, but this plate does nothing to address this posterior medial fragment. And it's got 1 or 2 screws just about barely hanging on to it. So this is not how you'd be treating these kind of fractures. The complications that we tend to see with the high energy injuries are these. Now, I can deal with articular collapse and malunion a lot easier than I can deal with wound infection. And wound infection really can scupper your chances of a good outcome. And in a worst case scenario, as I said to you, it could be a stage amputation. These are the things that you don't really want to see when you get these complex fractures coming through to you. And it doesn't matter how good you are, once in a while you will end up with this, with a completely fused knee, because there's no other salvage other than an amputation. I never want to hear any of my junior team coming to me to say that the incision was placed to avoid blisters, because they get the question, well, what the hell are you doing operating if there were blisters? Or that the wound was closed in layers under tension, which then again means you were operating when the knee leg was very swollen. So this is something that you should not hear. So as I mentioned to you right at the beginning, my basic principles of operating on these high energy injuries is span, scan, plan. And this is not just for proximal tibial fracture, this is for even distal tibial fractures, any of the sort of articular injuries which have very poor soft tissue around them. You can't go wrong if you have this mantra in your mind. And what you want to be able to do, as I said, is have clean surfaces, the plates in the right place, and no evidence of infection. And I would strongly advise, if you're using two incision techniques, to consider using a drain, particularly on the posteromedial side, because there is a lot of soft tissue, vascular soft tissue that is stripped out here, and patients tend to develop a hematoma. They won't develop compartment syndrome, but they do develop hematoma, which causes a lot of pain and then worries you enough to have to take them back to theater to wash them out. So having a drain for 24 hours and then taking them out after that is easy to do and saves you trouble. External fixators you can do. For me, they usually are used as a temporary device, and they sometimes, if they are very bad, then and the soft tissues are not settling, then we have to take recourse to external fixators. But it's not my first choice. And then there are fancy ways of doing all of these things. These are just some examples. So there are some newer techniques which are percutaneous, and we've tried these before, where you put a balloon in, you blow the balloon, that lifts the fracture fragment up, and then you put cement and you put some screws in. But remember, newer techniques come with newer complications. So the balloon can sometimes rupture. The cement that you put in can sometimes pop into the joint, as you can see here. These are cement pieces. And of course, when you're pushing the balloon in, the posterior part of the fracture is still vulnerable to be pushed back. So you are assuming that your balloon will only go up towards the articular surface. It can sometimes go back and cause problems. So newer techniques don't necessarily always come with the rate of success that is claimed for them. We do arthroplasty as well as primarily for these cases occasionally. I worked in a unit where we presented our data for a few patients, and they do quite well. But for me, arthroplasty is usually kept as a salvage situation for certain procedures. So here is one where this patient had a fixation. And what is interesting is if you look at this, you can see the trouble and the problem here. But the final picture that was taken in a sort of an acceptable position, and the surgeon obviously looked at it and thought it was okay. But the key here is you can't see the fibula, which therefore means that this is a externally rotated view. And clearly this fracture was not reduced, and it was more like this. So in a few days, when check X-rays were done, this is what it was. So obviously you can't leave it like that. So we take the theater and we put a primary knee replacement, which works quite well in these situations. The only good thing about the whole situation was, by the time I got to the patient, the soft tissues had all settled down. So it was actually much easier to do the joint replacement. Here's another one, and this is quite interesting. Again, you can see there's an anteromedial fragment and a posteromedial fragment, and then the sort of lateral side is intact. So the traditional, posteromedial and anterolateral plate concept won't work here. So this patient received an anteromedial plate and a posteromedial plate. They also had a posterolateral corner avulsion, which was repaired. And actually did quite well. And you can see, so this is for the posterolateral corner, ignore that, but you can see that was anteromedial incision there. And you can see the posteromedial incision here. You can see how far back it goes to allow me the ability to actually have 3 incisions here, all with significant amount of skin bridge to prevent any kind of skin compromise. This was a case that came to us again after having been operated on. Looks okay initially on the images, but when we took the check X-rays, you found that the knee was still sublux, so it was clearly not well reduced. We do a CT scan, and you can see that depression there that the condyle is falling into. So we take the patient to theater, and we put an external fixator on to get some traction out first, and then we basically redid the whole procedure, and the patient eventually got his knee back to a functional ability. It wasn't fantastic, but if I can get somebody from that state into a 100 to 120 degree flexion, I think I've done well. And then just finally, I'm going to go through what we are now using as our technology for these kind of complex cases. So here is another complex tibial plateau fracture, which was fixed with what assumes like, but looks like a reasonable fixation. The problem we had was, so this was a policewoman. She was 35 and she injured herself while running to catch a
Okay, walk now.
a criminal. So if you look at her walking,
Okay, turn around.
so you can see that she's gone in, dipping into, and so we actually had quite a bit of think about how exactly to deal with this, because we weren't quite sure what was going on with her ligaments and bones, and we took her to a theater and did an EU, and ligaments all seemed okay. So what we then did is we scanned her, and what we found from the scan was that she had a reverse slope in her tibia, and it seemed like that was causing the dip in the varus stance that she had when she was walking. So we did a 3D reconstruction of the whole tibia and found that this is what she had, and this is where we needed to be. And this is not just a question of doing a single osteotomy and lifting the medial condyle up, because that would cause a step between the medial and the lateral condyles. It was a bit more complex than that. And essentially what we needed to do was to go from here to here, and that included an osteotomy to elevate the tibial slope from where it was, and also we needed to externally rotate the medial tibial fragment that had been fractured and slide it slightly back so that there is no step between this and the lateral tibial plateau. So it was quite complicated, and sort of I'm lucky that we've got a set of very good computer experts and engineers who can work on this. And they basically drilled this model for us and said that this is the osteotomy we needed to do to get her back into motion. And that involved creating all kinds of model and also understanding the actual fragment that we would be taking out after our osteotomies, and that should be shaped like this. And if it wasn't, that means we hadn't done this right. So subsequent to that, to end up doing the osteotomy, we created patient-specific jigs using 3D printing. So these jigs were created. So this would go on either side of the malleolus. That would be our anchor point. And then we have this jig that would go in and allow two K-wires to be passed and anchored. And those K-wires would then allow this jig and this jig to give us the double osteotomy that we needed to create the correction. So there was a step-by-step guide. As you can see, this is the initial jig, and then these are the two subsequent jigs, and that should allow us to do this. So this is the 3D printed jig that we have. So we've got a 3D printer in our department. This is the jig. This jig was then used and put in here. These are the two guide wires anchoring the jigs in place. Then you do your osteotomy, and then you fix with plates and screws. And then the idea is to reverse that slope back. And then of course, after that, you see the patient walking, and she was back to her
and then turn back.
Job as a policewoman. But it took 2 years for this to happen, because we only got her at about a year down the line. So technology at the minute that we've got allows us to do these kind of analysis and do these kind of corrections. And I'm lucky to have this around. I realize not everybody does, but if we do, then it is time that we put these into action. So just to finish off, the main reasons for poor outcomes in tibial fractures are poor articular reduction and inadequate fixation with varus collapse. And of course, the others are self-evident. In summary, there's a range of personalities, both from the fracture, the patient, and the surgeon, and that has to be taken into account when you're treating with these fractures. If you have anatomical reduction of the articular surface and you can get absolute stability, that's fine. If you can't, then as I said, go more for the alignment and the stability. And that should allow you to get reasonably good results. Know your limits, be aware of the pitfalls relevant to the fracture personality, and of course, try and avoid complications. Thank you.
Thank you very much, Dr. Raj. That was a very interesting presentation with a lot of complicated patients and interesting answers. So thank you very much. I hand over the session to Dr. Diago. I kindly request Dr. Diago to share your knowledge and ask the questions.
Thank you, Saseendar. First of all, it's a pleasure to me to be here with you. Thanks for the opportunity. It's very good to share our knowledge between different cultures, different type of fractures, with the same result sometimes. Congratulations, Dr. Raj, Dr. Chirag. Very nice talks, very clear, very educational presentations. I would like to share with you a situation we have here in Brazil. It's a driver, we call them motoboy. It's a kind of crazy, no limit driver with their motorcycle. They drive in the middle of the cars, bus, trucks, and all you can imagine. They don't fear nothing. So we have a lot of plateau fractures here. Sometimes we have more 5 and 6 Schatzker plateau fractures here than an ankle fractures. So it's very good to see how different the patients are around the world when we are talking about different fractures. When I started as a traumatologist, we used to treat the X-ray views. And when I become a knee surgeon, I take care more about the soft tissues than only treat the bones. So the first question I would like to do to Dr. Chirag is about the arthroscopy, because I really like to do arthroscopy during my tibial plateau fractures treatment, because for me it's very important to understand how the knee is inside, not only to be sure about the reduction of the fracture or to be sure that the depression of the fracture is correct, is anatomic, but to know about the ligaments, to know about the meniscus, because sometimes we have very good X-ray views after the surgery, but the patients are not so good. And what I think is because sometimes we only treat the fracture. We do not treat a possible meniscal tear or even a ligament injury. So I would like to know how do you manage in your countries between the fracture and the treatment of the soft tissues? And when I'm talking about soft tissues, not about the skin or even compartmental syndrome, something like that, but talking about meniscus and ligament injury, that it's very usual when we have this kind of treatment. Hi, did you hear me?
I think we are losing him a bit.
Connection is
Yes. Okay. So my question is, do you think we should treat the ligamental and meniscus injury at the same time, considering we are doing arthroscopy, or do you think it should be treated in a second time?
Dr. Chirag? Dr. Raj, you can share your opinion.
Yes, so I mean, I tell my patients that, this is not going to be the end of their journey. It is just a start. And there are going to be, possibly more operations later on. I have to say, when I get the major injuries, I am so worried about generally the overall soft tissue and fractures that meniscus and ligaments for me become slightly more secondary. Of course, if there is something an obvious like an ACL avulsion that needs to be put back in, I will do that at the same time. Or if there's a posterolateral corner that needs to be fixed, as you saw in the previous examples, I will fix those at the same time. But I'm not looking to get the knee perfect and dealing with every problem at that one setting, because I agree and accept that there may have to be for further visits to the theater for the patient, particularly the 4, 5s, and 6s. 2 and 3s probably less so. 2 and 3s I'll try and do as much as I can in that one setting. But for me, 4, 5s, and 6s, they are just the start of a few operations.
Dr. Chirag?
Yeah, so we are talking about the meniscus and ligament injuries, isn't it? I lost in between.
Yes. Will you proceed with a single stage repair or reconstruction or treatment of the ligament and meniscal injuries along with the tibial plateau fracture? And if so, when? I'm sorry, I'm extremely sorry for the breakup. Dr. Raj, you are saying that type 1, 2, and 3, you might be thinking about a single stage repair or reconstruction. So will you proceed with a ACL reconstruction in these patients also?
So
It seems to.
very much on the patient. As I said to you, it's all about patient profile and fracture profile. If it's a young, fit, healthy person who's got an ACL avulsion, as in the tibial spine has come off, I tend to try and fix it at the same time using some stitches and bone tunnels. If it is an ACL stretch or might be a potential insufficiency, I don't, because I'd like them to rehabilitate from the bony injury, see how much of actual symptoms they suffer from. And because often in these fractures, they tend to cause some stiffening up of the knee, and the instability symptoms after an ACL damage are not as much of a big deal for them. So no, I would not proceed with an ACL reconstruction. I will certainly try and repair a tibial spine avulsion.
May I, Saseendar?
Yes, please. The
yes?
stage
Okay.
is yours. The stage is yours.
Okay. I really like to use external fixation devices temporarily, not definitive in most of the times. Dr. Raji, I would like to know from you and Dr. Chirag, when you decide to use the external fixation as a temporary device, and when you decide to do the conversion, to do the final internal fixation, not talking about the soft tissue injuries, but considering the type of fractures. I don't know, sometimes here we don't have the internal fixations devices at the same time as the patient comes. So I would like to know more about your routine, how it works, about the use of the external fixation.
So I'm lucky. I work in a type 1 major trauma center in London, so I have pretty much everything I need all the time, which is great. But I would never ever rush into a 4, 5, or 6 immediately, and they all get an external fixator as they come in. Firstly, as I said, to get us a bit more of time. So the other problem of major trauma centers are you're quite busy. You don't always necessarily have the time and the ability to go in for these 2-3 hour operations immediately. And I've also found that even if they look innocuous, if I go in early and do a 2 incision technique or one of these complex cases, they tend to swell up afterwards and then develop blisters later on. And I get sleepless nights for the next 5 days. So I would much rather have an external fixator, let it settle for 28, 24, 40, or even 72 hours. It allows the soft tissues and the fractures to declare itself where it is going to be, how bad it is going to be. And I've then realized that what kind of behavior I can get from the soft tissues. And then I will wait for everything to settle down and then operate on these. Obviously, we know that we tend to try and operate within 2 weeks because of the infection side. But for me, it's much more important to get soft tissue settling down. And sometimes I've waited even for 3 weeks. But the key is when I'm putting the external fixators, they must be far away from the zone of reconstruction so that you are not anywhere near the pin sites when you're putting your plates and screws in. So again, the instructions to the juniors or whoever is doing the external fixator is remember where you're going to be when you're wanting to do the reconstruction and put your pins far away from there. Wait for the soft tissue to settle down. I'd much rather do that than go in early.
Perfect. And in these cases, do you have any protocol for the vascular exam? I mean, to do arteriography or
yes,
kind of index?
All of, as I mentioned, all of them will get a CT angiogram. If they are Shaska 4, 5, or 6, they all get CT angiogram. And as I said, I want to also know, even if the vascular tree is intact, I want to know whether there's been any intimal damage, because if I'm going to put a tourniquet for 2.5 hours, I do not want that. And I will actually then stop myself using a tourniquet if I have to. So yes, as a routine, all the 4, 5s, and 6s will get a CT angiogram.
Very nice.
Dr. Diago, what is your protocol? What do you do? I'm sorry.
Yeah, it looks like similar. I think we have always to remember that sometimes we have a regular exam, arteriography or MRI angiogram, but sometimes we have an intimus injury and we are not seeing this in the exam. So sometimes we, mainly for 5 and 6 injuries, even with a regular, a normal vascular exam, sometimes we like to use external fixation device as a temporary, just to see how the vascular exam will continue during the 48 first hours, for example. Sorry.
First of all, thank you very much. Excellent for both the excellent talks, Raj and Chirag. I just wanted to ask, when you apply the primary spanning external fixator on conversion from spanning to definitive fixation, what is the role for ring fixators compared to definitive fixation using plates or internal fixation?
So I prefer, as I said, always internal fixation. I don't prefer ring fixators. I have some colleagues who do, and it becomes, I think it becomes a bit of a dealer's choice. Whoever has got the patients under their care, they decide if they want to go for external fixator or internal fixation. Personally, I will always go for internal fixation. I know equally there are some places where always go for external fixators. For me, the only reason I would go for an external fixator is if I cannot get the soft tissues to settle down and they're just looking bad and with blisters and swelling and time is moving on. And also if I find that the fracture is so comminuted that it is extremely difficult to reconstruct the articular area, and then ligament ataxis with minimal internal fixation, sometimes a couple of screws with external fixator is something that I would aim for. But as a rule, I very rarely would go for external fixator. I don't know what Dr. Diego, your preference is.
Dr. Raj,
let Dr. Chirag talk whenever his internet is working. Yeah, Dr. Chirag, yeah. Yeah, Dr. Chirag, please go on.
I got disconnected again.
You are not lucky. Dr. Diago, please go ahead.
No, I always prefer to use internal fixation. I like to solve the problem as fast as I can. But of course, sometimes I have to be ready to do a temporary external fixation just to be sure we don't have any other associated problem. I think it's okay, Dr. Chirag, now.
Yeah,
Dr. Chirag.
Frozen again. Raj, can I ask one more thing? You showed a patient with 3 fragment fracture, anteromedial and posteromedial fragments.
Yeah.
You put 3 incisions on him. Did you have to turn the patient over, or how did you position the patient?
No, all my tibial fractures, even if there's a 2 or a 3 or a 4 or a 6, they all have the same position. I like to be repetitive, so I don't have to keep instructing my team all the time. They all have their legs hanging from the front, and as I said, the posteromedial incision is the key, and that's why you have the leg slightly away from the end of the bed, so you can turn your drill and bring it from back to front. So my incisions for those were all the same. I think that the interesting thing is that the lateral incision on that patient was for posterolateral corner reconstruction. But yes, I could have used that and extended it to make an anterolateral plate as well, which I didn't think was required in that particular case. But position is always the same for me. I don't like to move patients around in the middle of the operation.
Okay.
How do you manage those requiring fasciotomy, compartment syndrome? When do you do the plating for them?
So if they are requiring compartment syndrome straight away, then they just have an external fixator. They have the compartment sort of decompressed. Then actually that's another situation where sometimes I will get my colleagues to do an external fixator, because if the plastic surgeons feel that they can't close the fasciotomy for a long time, then the best way of dealing with those at that stage is external fixator. But if they can close it within 4 or 5 days, then I would go in with them, do my plating, and then let them close the fasciotomy at the same setting. I would never do a insertion of the plating if I can't get the plastics to close at that setting. There cannot be a separate time frame to that.
And use of bone graft during internal fixation.
So bone graft is an interesting concept. People always talk about, that big gap and you pack it with bone graft and you close. I find every time I close the fracture, I don't have any more space for bone graft. It becomes a bit of a struggle. You put in bone graft and then you can't actually close the book and get your plate onto it. So I use bone graft very minimally, you have to say. I don't know what Dr. Diego feels. I mean, do you use a lot of bone grafts in your fractures?
Yes, not all the time, but as I do a lot of osteotomies, so I like to manage with bone grafts. If I use bone grafts usually from iliac crest, but sometimes I use synthetic bone graft too. For the plateau fractures, usually I use bone graft if the depressed fragment seems to be very unstable. So sometimes I use the bone graft. Sometimes if I just using the pin guide, I can put the correct place, and after we use the screw, the fragment is stable, so I don't use that. But just in case, I used to use.
Okay.
Dr. Chirag has typed in a couple of questions because his network is not wonderful. So here's how: is there any role of mini arthrotomy to see the lateral meniscus entrapment?
So I personally don't do a mini arthrotomy. I'm not sure I see the point of that. I'd either do an arthroscopy to see the lateral entrapment, or I'll open up to fix the fracture. So I'm not somebody who does. And also, if you do a lateral mini arthrotomy, then you always have the fat pad coming in way, so it's not a great vision anyway. Medial side you can, but I can get a lot better view with the arthroscopy. So I'd rather do that.
Yeah,
Dr. Diego?
me too.
Yeah.
Usually I do the arthroscopy usually, so for me it's very easy to see the lateral meniscus using only the arthroscopy view. It's okay for me.
Okay. Do you put the leg on a traction for the surgery?
I don't.
No. For Plateau fractures, no.
Yes. Okay. So, in your experience, in your series of stage, Shaskar 3, 4, 4, 5, and 6 fractures, what are the incidents of CPN palsy, that is common peroneal nerve palsy, and any tricks to manage them?
So the incident, I think I mentioned that it's actually not, it's higher than obviously 1, 2, and 3, but it's not massive, thankfully. 1 to 2% that I get to see. Obviously, you have to see whether there's been, and you saw a couple of cases I showed you, that if there is a posterolateral corner injury, I will go ahead, I will fix it, I'll explore the nerve, and I generally always have plastic surgeons helping me with those as well. And then if they're not getting better, then I usually put them in a foot splint. As long as I've seen the nerve is intact, then you just wait for them to recover.
Okay.
Yeah,
And Dr. Yak. Yes,
okay.
please, Dr. Yak.
I do a lot of complex knee ligamental injuries. So for me, it's not a problem to do a lateral approach, trying to move the biceps and identifying the peroneal nerve. If it's necessary, if I think it's necessary to do something, I try to release them, the nerve, and usually it's sufficient to know if there is a real injury or not.
Okay. Again, there is another question from Chirag. How do you manage fibular head aversions in these patients with tibial plateau fractures?
As I showed to you, sir, I would just go and do as I would any other fibular head avulsion. I don't avoid them. I don't leave them to heal by themselves. I go and address them.
There's one question from a couple of questions on YouTube actually. How do you differentiate between pseudo-laxity and MCL injury in acute setting?
So, I mean, this is obviously Dr. Chirag's point, so it's a shame he can't answer. But for me, obviously, the best way is compare with the other side and look what the other side is doing. And you can tell, of course, when there's a depression, that there's that part of the laxity is caused by the depression. But I think you will also know whether the MCL is stretched or not, which usually it is. As a result of that injury, the MRI comes in quite handy, because the MRI will tell you whether there has been a grade 1, grade 2 sprain, and you compare it with the other side on table, using fluoroscopy if necessary. Dr. Chirag, I think is back online, so you might want to talk on that, as it was his point that he raised.
Chirag?
I really like to, if possible, to try to do an MRI view from these knees before we do the surgery, if possible, of course, because most part of the patients come to the office after they treat the fracture with some kind of instability, and it's very difficult to do the MRI after we have plates inside the knee. So when I have these cases starting to treat the patients from the beginning, I always try to do an MRI, because I know it will help me a lot in the future. So just a tip that I always try to do, and sometimes it's a problem for me when the patients come back without this exam.
Chirag, are you in? Looks like he's frozen again. One more question from Dr. Prashant G. What is the ideal time to do ligament reconstruction if you are planning as a second stage?
So for me, it will depend on recovery from the first operation, bone reconstruction. I am in no rush to do a second stage ligament reconstruction. They need to have reasonable range of motion back. They need to be able to mobilize well, because another operation is only going to set back the knee a bit. And often you'll find that those screws can come in the way of your tunnels, etc. So I'm very happy to wait a good 6 months if necessary, because none of them are going to rush back to me with instability symptoms after a tibial plateau fracture. They're mostly going to, unless it's been badly reduced, they're mostly going to be complaining of stiffness, discomfort. So I'm in no rush to go for a secondary reconstruction of the ligaments at any stage. If there's an obvious MCL tear, or as I said, a posterolateral corner tear, those should be done either at that same time or within 2 weeks. That's my policy. I would not wait for those for too long, because they are essential for the inherent stability of the knee in the coronal and sagittal planes.
Dr. Diago?
Yes, we don't have to rush. We don't have to rush. First of all, we have to treat the fracture, because and these ligaments will not be very important during the fracture treatment, because the patients probably they will not using a lot his leg. So there is not a specific or an evident correct time we have to do the surgery, the second surgery. That's why I told sometimes we have to do the correct exam since the beginning, because if we have the correct MRI before we put the plates, sometimes it's very easy and it's very calm to prepare the second surgery, to prepare the final stabilization of the knee. For me, the most important thing are complete range of motion, or the best we can do for that, and some part of the quadriceps strain should be okay. We need the strain of the quad tendon and muscle to do this surgery. Sometimes it's very important thinking about the postoperative ACL reconstruction.
Okay, one question to Dr. Raj and Dr. Diago. If you have a lot of implants inside and possibly you need a multi-ligament reconstruction, and you're planning at 6 months, you're okay with completely removing all the implants?
No, so that's why I said if there are extra-articular parts of the ligament that are necessary for the knee stability, like the posterolateral corner, like an MCL, they need to be done in the acute setting, because otherwise those will not heal and they will not allow the patients to stabilize. If I'm going to be doing an ACL reconstruction, that is, as Dr. Diago also mentioned, is less of an issue. I might do it at a time where I'm able to safely take out some of the screws that can stop your tibial tunnels from being made. And I'm happy to start taking screws up at around 9 months if the patient has recovered well. I would not take out the entire plate at that time. To take out the entire plate, I wait for at least 12 to 15 months.
That's correct. Usually the screws are in the same way where we have to do the new tibial tunnels. So sometimes we have a total range of motion, sometimes we have strain in the quad tendon, but sometimes we don't have the total heal of the fracture. That's why most part of the times I used to do this final surgery after at least 1 year, when I'm really sure that if I took these screws out, it will not be a problem for the fracture.
So can I just add on, if I'm clear now?
Yeah.
Yes.
Yeah, I missed out a lot of the discussions, but I was just keeping a track somehow. Now, ACL injuries, as we said, is as I told in my topic, it's one of the most common injuries following this complex tibial plateau fractures, and we see about 50 to 60% of the times these patients have stiffness of the knee rather than laxity. I mean, they're quite stable. Most of them do not need an ACL reconstruction until unless it's an hyperlax individual, or else who's done aggressive physiotherapy, or else it's a young active individual who just tells us about that he's got a little bit of clicking sound, which actually is a pivot which is positive in this complete disruption. And also we see that the tibial plateau, configuration of the tibial plateau is altered. Now we all know that when the tibial plateau configuration gets altered, the pivoting is much more pronounced. So these are the individuals who are young, active individuals who have this kind of a periodic instability. Those are the individuals who require a second stage ACL reconstruction. And in our practice, what we do is once we have a little bit of a union, I mean a solid union at about say about 6 months or 7 months or say about 9 months, we just remove a couple of screws from the top and then use the ACL jig in such a fashion to escape these bone screws. You can have the tunnel a little more anterior and do your ACL reconstruction. We do not remove the plates and do the ACL reconstruction simultaneously because of two reasons. If I'm staging it, it will be 3 surgeries for him. And if I'm removing the same time when I'm doing an ACL reconstruction to remove the plates, it would be another morbid surgery and its rehab would get delayed. So what we do is percutaneously remove a couple of screws from the top, which would hinder our tibial tunnel, and then go ahead and do the ACL reconstruction. Our timeline is about 7 to 9 months post these fixations. That is one thing. The second is, can I just ask a question to Dr. Raj?
Yes, sure.
Yeah, Dr. Raj, hi. So I have seen a couple of my colleagues who do a lot of trauma work, extensive trauma work. They use this the traction device, which you use the leg hanging position to get that gravity reduction, isn't it? And an exposure to the all around the knee. So some of them use this traction kit, which we use for our IT fracture reduction. So what they say is like, one, you have a good exposure. Second is you have a ligamentautaxis, which aids in the reduction of these fractures. Do you believe in this?
So I find traction devices, I'm sure some people find them useful. I find them not very useful because I need all my muscles relaxed to get access to all the areas that I need to be in. The traction devices sometimes, because they're pulling on the muscles, they actually make it harder for me to get access to particularly the back of the knee. I need that flexion, not just for the gravity hanging, but also to allow the gastroc and everything to fall off when I'm peeling them up. There is no deforming forces in the fracture fragments when I'm relaxed in the leg. The traction limits a lot what I can do, particularly in the 4, 5s, and 6s. In the less complex ones, yeah, giving traction, putting a few screws in, that's not a problem. But for me, if I'm going to be plating at the back of the knee, traction does not allow me to get enough access. So I'd rather let everything be loose and use my direct approach to get access and reduce those fractures.
So one more tricky thing about these complex proximal tibial fractures are these fractures who come with the condyle fractures and a PCL avulsion.
So yes, again, if they come with the obvious PCL avulsion, then I will deal with the PCL avulsion as a separate entity. Again, not do it at the same time, because the PCL avulsion, you actually mentioned yourself as well that the ACL PCL are often in these cases are not such a big deal because they stiffen up. They generally stiffen up over time to the point that this doesn't really matter. If you've got a very obvious PCL avulsion that is come off and hanging at the back, and you really think that it needs to go back in, then yes, it will have to be for me a full posterior approach with the patient prone, etc. So I'll have to plan a bit. If I'm going to have to go posterior medial, this is probably one of the few instances where I'll go full prone posterior approach, fix the tibial plateau and the PCL. I have to say I probably had 1 or 2 in my career. I've not had ones where you've got these that pose a remarkable challenge.
Can I have one more question?
Yeah.
Dr. Saseendar? Yeah.
Yeah, sure, go ahead.
Yeah, for Dr. Digio and Dr. Saseendar and Dr. Srinivas, all the arthroscopic surgeons down.
Raj, can I ask one more thing? What is your age limit for doing primary arthroplasty? And what difference between a routine knee arthroplasty and this one?
So, good question. I don't actually have an age limit. I think I go more by fracture personality and personality. So if you've got somebody who's, generally low demand, and I know it's not going to need every bit of her knee or his knee to get on with the highly physical activities, then yes, possible. The cases I showed you are kind of salvage. That patient was 56, and to me, that was the best way to do the sort of salvage for her. If I'm doing primary arthroplasty on tibial plateaus, I tend to probably go towards the 70 plus. As it's very arbitrary, I've got no absolute cutoffs. Sometimes I'll just put them in a brace, tell them that I'm not going to do anything now, but once it all heals up, I'm going to go ahead and do an arthroplasty for you. I am ready to use stems and wedges as I need, so I always have them at hand. Usually the femoral side can be done with just a primary component. You don't need anything fancy. Is the tibial side that you have to be prepared to add or augment stems, wedges, whatever you need to. But I don't do that many primary arthroplasties for tibial plateau fractures. I tend to do a delayed primary arthroplasty.
How long is the usual delay?
So six months to a year, I think, is my usual delay. I want them to start walking again after healing, and I want to, just Dr. Diego mentioned, I want their quadriceps activity to come back. I want their range of motion to come back, and then we can do the arthroplasty.
Dr. Diego,
what is your graft choice in the second stage ACL reconstruction?
So I usually use allograft in these cases because I just don't believe I can get, I've messed around with the hamstrings and the pesa and surrounding that leg. I don't want to damage them more by taking a VTB. So I would use an allograft. And obviously, I know it's easier for us to get access to allografts, not for everybody, but yeah, I do that.
Dr. Diego, what's your choice? Dr. Diego, what's
we don't
your
have
choice?
we don't have a lot of allografts here, so usually we use autografts. I really like to use quad tendon.
Yeah, we use the quadriceps tendon usually for the second stage. Quad tendon is a good choice. I think personally, I feel quad tendon is the best choice in these scenarios. Like,
yes, I agree.
Okay. Do we have any other questions, Dr. Chirag, Dr. Srinivas?
no, I think you asked about the complex injuries which involve fibular head avulsions. These are very, very notorious. And we had a couple of cases with fibular head avulsions with the compound, with the complex fracture and with the common peroneal nerve involvement. These are tough cases to handle, and the outcome, I think, should be explained to the patient and very guarded.
Yep, totally agreed.
Yeah, any to Dr. Raj, any case scenario where you would go in and explore the common peroneal nerve in such scenarios on a primary sitting?
If there, so if I'm not going in to repair the posterolateral corner, I would not just go in to explore the common peroneal nerve. Obviously, I get an MRI scan, and if it looks like there is a posterolateral corner injury that needs to be dealt with, then I would go in and explore the common peroneal nerve at the same time. If it is, just a common peroneal palsy with, say, an undisplaced fracture of the fibular head, for example, I would not do anything for those. I'd let them settle down and see how they recover before exploring them.
Okay, Dr. Raj, a golden question, which is still a matter of debate for all of us orthopedic surgeons. What is the right time to operate a bicondylar fracture? You wait or you go primary and do it on day one?
I never go primary. As I mentioned before, for me, 4, 5s, and 6s, they all get an external fixator, and I go with the span, scan, and plan route. Not because they all have bad soft tissue injuries, but usually because if you rush in, then they develop the soft tissue injuries. The soft tissue injury then declares itself. Then you start getting fracture blisters, you're getting swelling, you're getting all these bruises, and you start quivering about whether you've made the right choice or not. If you put in an external fixator, wait for 5-6 days, and then go in. You will very rarely regret that. So in my books, I never go for a bicondylar fracture straight away.
Okay, that's a very useful tip. I think we should all take it in a positive sense. Probably.
Dr. Diago, do you always proceed with the external fixator also for 4, 5, 6?
You're on mute.
Yeah. So,
You're on mute.
yeah.
Oh, sorry, I pushed the button. Sorry.
I'm sorry.
I
The same
agree.
time you pushed, I also pushed you.
Okay, I agree with Dr. Raji. I prefer to do in 2 times. Sometimes I do primary, but I'm sure we have a lot of different injuries, not only the bone. So for these more complex knee fractures, sometimes it's better to wait and see, and then we do the conversion for the final fixation, internal final fixation.
Yep, I think we don't have any more questions. That was a very, very wonderful program with a lot of complex injury discussions. And I think there was a lot of take-home message for both youngsters and also the more advanced trauma surgeons and arthroscopy come trauma surgeons. I think, a lot of orthopedic surgeons should have benefited from today's program. Thank you very much, Dr. Raj, Dr. Diago, and Dr. Chirag for making this a wonderful program. And thank you, Dr. Srinivas and Dr. Ashok Shyam for making this program possible through Ortho TV also.
Thank you. Thank you again for having us.
Thank you.
Thank you so much.
Yeah,
thank you. We hope to see you all again sometime in the future.
Thank you.
Yeah, see you.
Bye-bye.
Bye-bye. Stay safe all.